This East EGS Minute reviews the 2015 study by Dr. Riggle and colleagues, analysis of omitting biliary tract imaging in patients with biochemical evidence of choledochlorithiasis. There is currently no consensus on the management of possible choledochlorithiasis. Debate exists regarding the diagnosis and clearance of the common bile duct in the setting of biochemical evidence of choledochlorithiasis. Management of choledochlorithiasis includes preoperative or postoperative MRCP and ERCP or cholecystectomy with cholangiography to determine if there is a retained stone. Dr. Riggle and colleagues sought to determine whether it would be safe to manage choledochlorithiasis in patients with rapidly downtrending liver function tests with cholecystectomy without additional imaging of the biliary tree. Their hypothesis was that most stones will pass on their own without consequence, and thus imaging of the biliary tree through cholangiography, ERCP, or MRCP can be safely omitted in these patients. This was a retrospective review over an 18-month period. Dr. Riggle and colleagues included all patients that were admitted to their ACS service with biochemical evidence of choledochlorithiasis who underwent cholecystectomy without undergoing any pre-op or intra-op imaging of the biliary tree. There was not a set protocol for management of choledochlorithiasis, but the majority of attending physicians managed these patients in a similar fashion. If the patient's LFTs trended down the following day, no additional imaging was done, and the patients underwent cholecystectomy. If there was a persistent elevation or increase in LFTs, post-op ERCP or MSCP was performed. Biochemical evidence of choledochlorithiasis was defined as any elevation of AST, ALT, ALK Phos, T-bili, or lipase. Patients without persistent elevation of LFTs were followed to assess the need for additional post-op imaging and/or intervention. Over an 18-month period, 668 patients were included in the study. Patients with postoperative choledochlorithiasis were compared to those without evidence of postoperative choledochlorithiasis. 646 patients, or 94% of the cohort, had no evidence of post-op choledochlorithiasis compared to 22 patients that did. There was no difference in average age, gender, BMI, or length of stay. The common bile duct diameter was significantly larger in the post-op choledochlorithiasis group, 5 millimeters versus 3.8 millimeters. Out of 668 patients, 38 patients had suspicion for retained stones either due to elevated LFTs or ongoing pain. All of these patients underwent ERCP and/or MRCP. 22 patients, or 3.3% of the overall cohort, were found to have a retained stone. This was identified on the index admission in 10 patients and on subsequent follow-up in 12 patients. The average day of diagnosis was 49.8 days in those patients that were diagnosed on follow-up. Only one patient in the study developed cholangitis. The LFTs of the patients with postoperative choledochlorithiasis were compared to those without evidence of retained stone. The post-op choledochlorithiasis had significantly higher ALT, AST, and total bilirubin on admission than those patients that passed their stone. The authors concluded that in patients with rapidly downtrending LFTs, imaging of the biliary tract could be safely omitted and patients can proceed directly to cholecystectomy. Retained stones rarely cause significant issues and can be safely managed with ERCP once identified. The authors propose that this management of choledochlorithiasis can help to minimize unnecessary imaging and procedures without compromising patient safety.